Hello everybody, this is Carlos from Army of Nurses and welcome to another video. Today's video will be talking about post-anesthesia care and complications. Some of the topics that will be covered will include cardiac arrhythmias, hypoxia and hypoventilation, hypotension and hypertension, sepsis, wound and incision care, nausea, vomiting, post-op pain and discomfort and anxiety, and last but not least, malignant hyperthermia. So let's start with cardiac arrhythmias. So cardiac arrhythmia is an irregular heart rhythm, and they can vary from being asymptomatic and chronic to being acute and lethal. Some of the causes for cardiac arrhythmias include hypoxia and hypoventilation, electrolyte imbalances, low blood pressure, hypolemia, and some paralytics such as succinylcholine. Some of the treatment modalities for arrhythmias include, if the patient is unstable, we're going to go for electrical treatment or cardioversion. If the patient is more stable, then we will try medical treatment with antiarrhythmic medications. We'll provide the patient with supplemental oxygens, replace any electrolytes as needed, or try to remove excess as needed. We will perform 12-lead ECGs for continuous monitoring, and we will perform blood work to ensure that it has not changed from the baseline. So hypoxia occurs when there's not enough oxygen to meet cellular demand. It is manifested by low saturations, PO2 less than 60, and ventilation perfusion mismatches. So there's three mismatches that it can happen. It can be a high ventilation and low perfusion, which is called dead space. There could be low ventilation and high perfusion, which is called shunting, and there is low ventilation and low perfusion, which is called a silent unit. So some of the treatment modalities for hypoxia include providing supplemental oxygen with a proper delivery device. This can be pretty much anything from nasal cannulas all the way to endotracheal intubation. And we have to find and treat the cause of the hypoxia. Hypoventilation occurs mainly as a result of a very low or weak respiratory drive, and this can be the result of weak respiratory muscles, airway obstruction, laryngospasms, and oversedation. So hypoxia and hypoventilation, sometimes they go hand in hand. Hypoventilation will lead to hypoxia. Hypoventilation could be the result of depression of the respiratory drive from anesthetics, sedatives, and analgesics. This will lead to a low respiratory drive, which leads to less inclination to take deep breath. This in turn will result in low tidal volumes and poor gas exchange, meaning that CO2 cannot be removed effectively and oxygen cannot enter the blood efficiently. Hypoxia occurs, and when hypoxia occurs, then there's ischemia to cells. So when there's ischemia to cells, then whatever organ is affected by the ischemia then will manifest certain signs. For example, in the heart, any ischemia or damage to heart cells then can cause cardiac arrhythmias, which goes back to the first few slides that we talked about. Now, hypoventilation, some of the treatments for that include intubation and mechanical ventilation support. We need to treat and find the cause. If there is an obstruction, we need to deal with it. If it's oversedation, then we can use reversal agents. For opioids, we can use naloxone. For benzodiazepine, we can use flumazenil. And for paralytics, we can give fluids and acetylcholine. Hypotension, it's quite common as a post-op complication, and this could be due to blood loss, either from the wound or the incision, due to fasting, as patients are told not to eat or drink, then they will not be able to absorb as many nutrients and fluid, leading to a lower blood pressure. Sedation due to the dilation of arteries. Sympathetic blockage, some anesthetics have that effect, so it blocks the sympathetic nervous system. Therefore, the parasympathetic nervous system becomes stronger. Sepsis, pulmonary embolisms, and blood transfusion. So for hypotension, if the patient is bleeding and that's the result of the hypotension, that's what's causing the hypotension, the bleeding, then we have to find the source and stop it. Transfusion of blood products include PAC cells, platelets, fresh frozen plasma, and cryoprecipitate might be indicated to stop or further, stop the further loss of blood. Fluid resuscitation will be necessary to treat the hypotension. If the hypotension is caused by sedation, then reversal agents. If all of the above do not work, then we might want to add medications that help increase the blood pressure, called inotropes and vasopressors. What they do is they increase the contractility force of the heart and also squeeze the arteries, therefore increasing pressure inside the vasculature. And positioning also helps. So if patient is hypotensive, we usually try to put them on their back. If they're able to tolerate it, then Trendelenburg is a good position to put them on, just so that a lot of the venous returns to the heart, and the heart has enough preload to continue pumping the blood in the vasculature. Hypertension, on the other hand, or high blood pressure, three of the main causes include pain. Obviously, pain triggers a sympathetic stimulation and causes tachycardia, hypertension, and causes the body to be in a state of stress. Hypothermia can also cause hypertension in the sense that when patients are cold, then they tend to shiver and they tend to constrict they tend to constrict their vessels more. So the constriction of the vessel will lead to a higher blood pressure. Also, anxiety, as a matter of fact, it will cause hypertension as well. And it's mainly due to the stimulation, or the overstimulation, should I say, of the sympathetic nervous system. So some of the treatment for hypertension includes: 1, effective pain management, which is very important for patients with post-op care. Warming the patient if the patient does feel cold. You can try warming blankets or adding additional blankets if your unit does not have a warming blanket. Prevent the anxiety or treat the anxiety, and use antihypertensive medications to lower the blood pressure. Now, sepsis, it's can be quite common and can be quite fatal in patients with post-op. So sepsis is an overwhelming infection that the body is dealing with. Some of the causes include a failure to practice sterile technique or aseptic technique during the surgery. Also, some of the induling tubes and drains that are put in the patient during an operation to help patient drain fluid can cause sepsis. Remember that those are foreign objects. They're not meant to be in the body, right? So they become vessels for harvesting and growing bacteria if proper care is not provided. Complication of the surgery can lead to sepsis, especially abdominal surgery. Anything that can hinder the barrier in the gastrointestinal tract between the gut bacteria and the blood. If there's anything that disturbs that barrier, either because there is it was accidental puncture from from surgery, or repair from surgery, anything that disturbs that barrier gives the chance for bacteria to seep into the blood and cause sepsis. Another way to cause sepsis post-op is aspiration pneumonia, and the most common thing to happen is when patients come to the unit and they're usually drowsy and lethargic following anesthetics and anesthesia and sedation. So when that happens, when the patients are overly sedated, they lose their gag and their cough reflex, or such reflexes become very weak. When this happens, then patient is unable to cough secretions or is unable to keep gastric contents in the stomach. So what ends up happening is gastric contents can pass the epiglottis, can bypass the epiglottis and go into the sterile field of the lung, causing a pneumonia. Now, if this pneumonia becomes very severe, then patient can become very septic from it. Last but not least, another source of sepsis are the nosocomial infections, also known as hospital-acquired. So, as we know, hospitals are not clean places, so there is a lot of sick people gathered in a small place. So, the risk for transmission of diseases is quite high. Therefore, it's very important to practice hand hygiene and infection control precautions to isolate the patient for the patient's safety, for the staff safety, and also for the safety of the rest of the patients. So some treatment modalities of sepsis include early initiation of antibiotics, collection of culture samples, including blood, urine, sputum, swabs from the incision site, might be odor, or even the drain or the fluids from any exudates can also be cultured. Once those cultures, the results, they come back, then the antibiotic can be enhanced and can be changed to treat whatever's growing in those cultures. Fluid administration, very important in sepsis. Remember that when someone is septic, the bacteria causes massive vasodilation, so we need to fill the vasculature with fluid to prevent a further drop in pressure. If that is not sufficient, then we have to start inotropes or vasopressors, medications that artificially stimulate the heart to contract harder, and also to it stimulates the arteries in the body to constrict, to create a pressure, or to increase the blood pressure might be necessary if fluid administration by themselves is not helpful enough. Also, we might want to optimize the oxygen level of the patient. If the patient is breathing on their own, then we can titrate the patient to the amount of oxygen they need. However, if the patient becomes lethargic, obtunded, and is not able to protect his airway, then endotracheal intubation might be required to provide patient with ventilation, oxygenation, airway protection, and secretions if the patient has any. And again, infection control precautions, putting the adequate patient under isolation to protect the patient, the staff, and other patients is very paramount in the prevention of spread of diseases. Now, wound care and incision care, we are going to obviously look for the appearance. We look for the approximation of the sutures, of the staples. We look at the surgical incision, how it looks, if it's clean, if there's any exudate. We obtain a baseline to have something to compare it to as we progress with our assessment throughout the day to see if there's any changes for the better or for worse. Also, if the patient is showing any bruising or hematoma around the surgical site, it would be wise to mark the hematoma or the bruising site with a surgical marker just to see if it expands over time. If it does expand over time, it would be worth bringing it up to the surgeon or the doctor because the patient might be bleeding internally, and it's something that it's quite insidious, right? Internal bleeding. This chart, we're going to look for 4 things. We're going to look for color, odor, consistency, and amount. Short form for COCA, C-O-C-A. So color, odor, consistency, and amount. right? And we're gonna follow sterile wound care. So review your wound care procedure. Read your institution's policies about wound care, but wound care overall needs to be sterile as possible to prevent further wound infection or introduction of new bacteria into the wound, which can cause the infection to become more severe. And we have to check all drains for functionality. Make sure that whatever drain is in there is draining the amount that it needs to drain, is draining the color it needs to drain, or that it's draining overall, right? Because if the drains are not, nothing is coming out, that means that fluid might be piling inside the patient's abdomens or other places where fluid can actually start to pile up. So we also look for discharge, what is draining from those drains, and also look for securement. The last thing we want is that the drains can actually be pulled out accidentally, either when we ambulate a patient or when the patient turns himself or when we turn the patient. Sometimes those things can get kinked somewhere and they can pull. Aside from the severe pain that the patient might be in from accidentally pulling the drain, then it's actually can be quite detrimental to the patient, because if they still need the drains to pull out all the stuff, then they would not have that. So be very careful with that. Nausea and vomiting. These are common side effects of opiates. So nausea centers are found in the medulla, and they receive information from the GI tract, from the labyrinthian apparatus, visual inputs, and all those things. So patients who have, for example, excessive stimulus, visual or auditory stimulus, sometimes can lead them to have nausea. Also, patients who have gastrointestinal symptoms, sometimes they're also found to have nausea as well. And the significance of nausea and vomiting is due to the very high risk for aspiration. Again, patients who are post-op, they might be lethargic, unobtunded, because of the anesthetics and analgesic that was given during the operation, and this will inhibit their cough and gag reflex. So when this happens, put them at a higher risk for developing aspiration pneumonia. When that happens, ensure that patient is turned to the side and patient is given proper antiemetics, right, as a treatment modality. IV fluids, because as the patient starts to vomit more and more, he's going to lose more fluid, so we need to replace those since the patient is unable to take those by mouth. Try to decrease the stimulus, either auditory or visual stimulus, that can help with the nausea. Set up a suction. And this is important because if the patient does end up vomiting and the patient is a big patient and you do not have the help to turn the patient to the side by yourself, either because the patient is too big or you're unable to do so yourself, then not having the suction will 100% put the patient at risk for having aspiration. So having the suction set up allows you to get a lot of the secretions out and at least minimize the damage if the patient is to aspirate, right? So obviously the best thing to do would be to turn the patient to the side, but sometimes if you're unable to do so, always have a suction kit set up before your patient even comes to your unit. And frequent monitoring, which is quite necessary, especially if you're given medications, and if the patient is vomiting frequently, so it's always good to follow up with that. So post-op pain, some of the sources include the surgical incision, tissue damage, as the surgeons go in there, trying to fix stuff. A lot of the tissues, they move to the side, so there's like a lot of shuffling and tossing around, so that could cause some tissue damage, which could lead to residual pain after surgery. Also, surgical placements of tubes and drains, like I said before, those are foreign objects, pretty much instilled inside the body, which they're not supposed to be there. So sometimes, they irritate tissues around it, causing discomfort and pain. The psychological state of the patient to tolerance in pain, that's very important because everybody has a different threshold for pain, and depends on their state of mind, they perceive pain in a different way, right? So if patients have a more positive outlook, or a more positive thoughts, they tend to tolerate pain a little better than patients who do not have a good psychological state. Swelling and inflammation obviously can cause some pain, mainly because the swelling starts to occupy space under the skin, inside the body, and that swelling starts pushing around some nerves, squeezing them, leading to pain. And performance of a pain assessment is very important. Use your PQRST, use happy faces scale if you have to, or some people, they do not understand the number scale, so you can ask them how much pain, very little, medium, a lot, extreme, just use anything that you think will help you communicate your assessment to the patient. Treatment modalities for pain include, they should be holistic, not just analgesics. So narcotics and co-analgesics. Your co-analgesics include your Tylenol, your Advils, your non-narcotics, and they should be used together if there's no contraindications, because they do complement each other by working slightly in a different way to tackle pain. Anti-inflammatory medications. You can also use ice to reduce the inflammation. Referral and counseling. So referral and counseling it's important in a patient who has uncontrolled pain, even given the amount of medication that they're prescribed, right? So some patients, because they have such a low pain threshold, they are constantly in pain and they need a lot of medication to keep them comfortable. However, sometimes when it comes to that situation, pain management is not the best. So always trying to refer the patient to acute pain services early on, when there's an anticipation that the patient might need a lot of pain medication to keep them comfortable. It's always a good thing to get the referral started early. Heat and cold, sleep and relaxation techniques. As the patient is able to sleep and relax more, sleep is very important in recovery and healing of the body. Deep breathing exercises, less pain. Patient tends to take more deep breath, use the incentive spirometer more often, decreases the risk for atelectasis, decreases the risk for pneumonia, increases oxygenation, decreases ischemia. So all those good things. And also try to get the patients ambulating early on, increase their mobility early on, because if the patients are able to move more, then they remain in the hospital less, and their recovery gets expedited, right? Because moving early on prevents stiffening of the muscles, prevents blood clot, increased circulation, all sorts of beneficial stuff for the patients. Treating pain also includes anxiety. Patients who are anxious, they tend to have more pain. So by treating anxiety, sometimes pain perception becomes less. And distraction and guided imagery, obviously you would do that for patients who are able to follow commands and are oriented. Try to distract the patient from the current pain. Ask patient for any interest that they have, engage in conversation. All those things can also help manage pain. Last but not least, malignant hyperthermia. This is an inherited condition. It causes skeletal muscles to become very sensitive to anesthetic drugs, and the muscles stiffen up and they become very tight and rigid. So it's a hypermetabolic response to a lot of anesthetics. It occurs in the perioperative stage. That means the stage where patients in the actual operation, where the anesthesiologist is giving the anesthesia. and it's triggered by inhaled anesthetics such as halothane and some depolarizing paralytics such as succinylcholine. It seems to be more prominent in people with muscle abnormalities, such as a patient with myasthenia gravis, for example. And how this presents is usually the muscle patients present with muscle stiffness and rigidity. They could be tachycardic, blood pressures on the lower side. They could present with metabolic acidosis, and the acidosis happens due to the increase in metabolic rate due to high temperatures. So higher temperature equals higher metabolism. However, oxygen, it remains at the same amount in the blood, right? So you have higher metabolism with the same amount of oxygen. So when this happens, there isn't enough oxygen to supply aerobic metabolism, so the body goes into anaerobic metabolism. Anaerobic metabolism produces lactic acid and leads to acidosis. And of course, hyperthermia, temperature greater than 40, so patients do become quite hot. And this can be a problem if it left untreated, because the brain is very sensitive to temperature changes, and damage to brain tissues can occur very quickly. Treatment includes stopping and discontinuing the anesthetic if the anesthetic's been given. If it has already been given, then there's not much you can do other than supportive measures. Provide 100% oxygen, FiO2. Apply cooling blankets or ice in groins, under armpits. When we use a cooling blanket or the ice, just ensure that we check the skin and we check CSM, because they can actually cause some, frostbite. Cold saline might be ordered, and just remember that cold saline has to be given peripherally, so either via a peripheral IV or a femoral central venous line. It's contraindicated in subclavians and jugular and internal jugular central venous lines or central lines, and the reason is because when it's given distally, it gives more time for the cold saline to mix with the blood and decreases the risk for myocardial stunning. So by stunning, what I mean is when the heart encounters the cold saline, what ends up being is it goes into this hypometabolic state where it decreases and the conduction of electrical signals in the heart decrease. So when that happens, the heart rate drops very, very quickly, and the patients can become very bradycardic, or they can go into other lethal arrhythmias. So always give peripheral via peripheral IV or a femoral central venous line. Okay, dantrolene sodium, it's the drug of choice for malignant hyperthermia. It is a muscle relaxant, and what it does is it relaxes a lot of the stiffened muscles, so that it also controls the ongoing temperature climbing. And patients might also need to be admitted to the intensive care unit for monitoring, because they need close observation, especially after having malignant hyperthermia, because the patient can become quite unstable very quickly. So that's it for this video. Thank you very much for watching. Remember to like and subscribe, and I'll see you on the next video. Thank you very much.